Hello, Sen. Before you go, can you hear me okay? Can you hear me?
Okay.
Yeah. Make sure Yuha's computer is working good, a good speed, okay?
Okay.
And it's the same way. I send a link like today and Yuha comes in like you did.
But I think you have
No, the next week, when he does his presentation, I send a link. You understand?
yes.
Yeah, the same as today, the same, but next week.
Okay.
Okay, so we keep in touch. You have to go right?
Right. Yes.
Okay,
Because
listen, we have China Grand Rounds next Saturday at 9 o'clock China time, 9 o'clock at night. But
okay.
I tell you about it. Someday you can present your paper.
Okay.
It's in Chinese. Okay, the
Okay.
webcast is in Chinese. Okay,
I'm very glad to do that.
good, very good. Okay, let's see who else. Musindo is here. We're getting very popular here, Sen. With
Yes.
30 neurosurgeons. It's good. Musindo.
Yes. Hello,
Hi,
John.
how you doing today? Musindo is
I'm
from
fine.
Mozambique. How you been?
Yeah. Yes. Now I'm fine. And you? How are you?
Oh, I'm sorry. I'm sorry. I was distracted. Musindo, this is Hu Sen. He is working with Yuha in China.
Okay.
And Musindo Hu Sen is neurosurgeon in Mozambique.
Resident, neurosurgeon resident.
Oh, resident. I'm sorry. What
Yes,
year?
resident.
What year are you?
This year is my third year.
Third year. Okay.
Yes.
He likes these webcasts.
Yeah. Too much. I try to.
That's good. That's great.
How are you?
So, Sen, I'm on the beach here. Sen, I'm on the beach.
Yes.
Yeah. No, it's illegal. People are on the beach. You're not supposed to be on the beach.
And your home is very nearby the beach.
Yeah. It's 1 mile away, the beach. 1 mile. It's very close to here. It's a nice beach, but now empty. Nobody on the streets.
Oh.
In Beijing, are people on the street now?
No, and in Wuhan, maybe 4 days later, and the government will allow the people to go outside, and now it's still the government still asks people to stay in home.
Oh, okay. I didn't know that. I thought they could go outside, but it's the same in here. And everywhere I speak, everywhere, all the neurosurgeons I talk to. Hello, Dr. Select. All the neurosurgeons I talk to, the same. No, nobody can leave their home.
It's a worldwide side. It's a worldwide disease.
Well, we go for food. We can go for food. We go to the store for food.
Yes. 1 month ago, it's the same in China.
The same. You can go for food.
Yes.
Yeah. Okay. Same. It's the same. Same. Hello, Dr. Oh, go ahead. What'd you say, Sen?
I'm sorry, I have to go out.
Okay.
Out of line.
Nice to see you again. And now we show Yuha to the world.
Yes.
Yes. And we show China to the world. China neurosurgery.
I think in neurosurgery in China, we're very happy to use your website and to show China to over the world.
Yes, yes, yes. And now is a good time because many neurosurgeons want to see Yuha and they are at home now. Before everybody's working, but now is a good time because many neurosurgeons can see him instead
Yes.
of working, and they're too busy. They cannot see him now. Good time.
Yes.
So,
See you later.
okay, thank you for coming, and I'll see you.
I'll see you.
We can have more web chats. Okay, tomorrow, Monday, whenever you can. Okay.
Okay.
Okay. See you.
See you.
Bye bye. Greetings, everybody. Would anybody like to introduce themselves? You don't have to. But if you do, just unmute and say hello to John. Okay, there's a mute button. Let me show you where it's at. I'll unmute all of you. Okay. Okay. Hilario Paul, are you there? Or Dr. You know, if you wanted to put your name, you know, to kind of look a little professional about it, you see the name below my icon. Up in the right corner of your icon, there's 3 dots. Okay, you can click on that and it says rename. That allows you to put your name below. So it kind of looks like Hilario has it. I can see that. But the other, Musindo, you don't have it. Musindo. Okay.
Hello, John.
Yeah. Oh, yeah. You got your name right. You got your name right below there.
I can.
No. It's. I was just talking about something, but you're okay. You've got it. You've got it.
Okay.
So how are things with you? You at the hospital or at home?
Now today I am at home because in this day we are not working every day. Eh?
Yeah, you're lockdown. No, people cannot leave house, right?
Oh no, completely. No, it is level 3.
Yeah, in Miami, huh?
Nah.
Okay, he's here. Hello, Dr. Yi.
Hello, John.
Hello, Dr. Yi. How you doing? Should I call you Dr. Yi?
Yes.
Okay.
Sure.
Okay. How you doing?
Good. I'm good. How are you?
Good. So you're all set, right?
Yes.
And you're a pro at this with PowerPoint and everything. So don't have to.
什么意思啊？ 不是吧？有个事儿啊！这是我问。
Can everyone check their sound, please? Because yeah, Dr. Yi, I've been having problems with introducing people. Like, you know, sometimes people hear it, sometimes they don't. I've been cutting that out now and waiting to the end to introduce people, you know. So
Yeah.
hello, docs. I know Gautam, you know this platform, right? Good morning, Gautam.
Good morning, John. Good morning, Ray.
How you doing?
Yeah, fine.
You're getting to be a regular.
Yes. because of lockdown.
Okay, yeah, Lucindo, yeah, there's not too many. We could probably go around.
No, John, my first name is Yi, and the second name is Guo. So the Guo is my family name.
Should I call you Dr. Goa or Dr. Yi?
You can call me Yi and Dr.
Lee?
Guo.
Yi is your first name, like?
Yes.
Okay. I'll just say Yi.
Yes.
It's not formal and it's not, I'm not
Right.
being graded.
And when I worked in UCSF, and they also call me GY.
Oh, really? GY?
Yes. Yes.
Oh, yeah, that's like JB. They call me sometimes,
Right.
like John Bennett instead of JB. GY, like that. Dr. GY. Are you working? You're not working today? You just got off work?
Yeah, I'm on my shift. And,
Oh, you're at the hospital now?
Yeah.
Oh, cool. Okay. hold on. Yeah, we're getting regular crowd here now. Dr. Kartik. Dr. Hafez. Okay. Neuromind. Oh, is that, I want, Peter, is that you, Peter? Neuromind? There's Neuro, is that you, Peter Kerbin? Peter, is that you? Neuromind? You know the app, right? Dr. GY? You know that app, Neuromind? Have you seen that app?
No.
Oh,
No,
okay.
I don't know.
Oh, okay. It's more like it's very popular app over here in neurosurgery. I think it's the most popular. It's written by a neurosurgeon from the Netherlands. Okay, you're almost ready?
For what?
Hello, Khalif.
Yeah, the Neuromind is used for what?
Oh, okay. Neuromind is an app. It's more or less, well, just check
Oh,
it
I
out.
see.
Go to the App Store
Yeah.
and look for
I see it.
Neuromind.
Yeah, I see it. Okay.
Okay. Okay. Okay, we're about to start. Ready, GY, Dr. GY?
Yes.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami. This is Dr. John Bennett broadcasting for Neurosurgical TV. Today we have the pleasure of having Dr. GY from Beijing giving a couple of presentations. And before we turn over to Dr. GY, let's just quickly go around the panel to see if we can introduce some of the people. Dr. Abbas Walid, could you please introduce yourself?
Yeah, hi, can you hear me?
Yes, we can hear you.
Yeah, I am Walid Abbas, Assistant Professor of Neurosurgery from Egypt.
Oh, welcome, welcome.
Welcome.
Okay, Dr. Huawei, if I'm pronouncing that correctly. Dr. Hafez.
I am Dr. Hafez, 6th-year neurosurgical resident from Palestine, Jerusalem.
Okay, you were here yesterday, right?
Yes.
Yeah, welcome back. Dr. Kartik Multani. Oh, perhaps he stepped away. Rahul, are you there?
I am Dr. Rahul here from Kerala, final year resident, neurosurgery.
Okay, welcome.
Yeah.
Welcome. Khalif, could you please introduce yourself?
Yeah, I'm Khalif from Kenya, 5th year resident.
Okay, welcome, Khalif. Okay, Dr. GY, I think we've got everybody. We'll meet other people later, but it's all yours, and thanks for coming.
Okay, thank you very much, John. And hello, everyone. And I'm Guo Yi from Beijing, and I'm a attending physician working in the Tsinghua Hospital, Tsinghua University, affiliated Beijing Tsinghua Chang'eng Hospital. And yesterday, Dr. Ip Cherian shared his cases about the basilar apex aneurysm. And today I will show some case of mine. And in China now, most of the basilar artery bifurcation aneurysm was performed by the endovascular surgeons, especially in Beijing. And so we seldom have chance to do the open surgery. So today I will share two basilar artery aneurysms. So I will share my screen.
Okay.
Okay.
There we go. You're sharing. Right. You're sharing.
So you can see now, right?
Yeah. You're just going to make the screen bigger. You'll get it.
Okay.
No hurry. Yeah. Beautiful.
Okay.
Beautiful.
So this is the first case is a 60 years old female. She suffered a sudden onset of severe headache for 30 minutes and then transferred to our hospital. And the patient preoperative GCS is E1, V1, M5, and the Hunt-Hess scale is a grade 4. And this is the CT scan. We can see a severe subarachnoid hemorrhage and the obstructive hydrocephalus. And the 3D reconstruction of the CTA, we can see the basilar artery bifurcation aneurysm here, and the branches of the basilar artery as clear. And the surgical options for such case are endovascular coiling and clipping. So I routinely selected the orbitozygomatic approach for clipping such case for such a aneurysm, and we can simulate the surgical approach on the 3D reconstruction of the CTA. And this before the craniotomy, we do the contralateral EVD, and then this is the incision. And I would like to do the one-piece orbitozygomatic approach. The orbitozygomatic approach usually include 3 ways for the orbitozygomatic unit: the one-piece and two-piece approach, and modified orbital unit that does not include the zygoma. So I would like to do the one-piece orbitozygomatic approach. And here's the video. And at first, open the basal systems insist that occur the arachnoid membrane, and enlarge the incision. Here is the optic nerve and the internal carotid artery. And then remove the clots in the basal cisterns carefully and open the arachnoid membranes. And to do this approach, after release some CSF from the basal cisterns to make the brain legs, and then open the sylvian fissure widely. But for such a severe subarachnoid hemorrhage case, it is a little bit difficult to split the sylvian fissure. So you can use the from the proximal to distal technique, or the distal to proximal and technique, and combine the inside out technique. So here it's a little bit difficult from proximal to distal. So then back to the distal of the sylvian fissure, and to do the inside out technique. You can see there are a lot of clots in the sylvian fissure. So carefully remove the clots and then incise the arachnoid membrane. After the sylvian fissure is split widely, and then the frontal and temporal lobe can be retracted, and the panorama view of the basal cistern structures can be clearly seen. So here, you can track the frontal lobe and then the temporal lobe. The tip of the retractor put on the surface of the uncus. And then we can see these structures. This is the liquid membrane. And here we can see a beautiful view of these structures, because this is a right-sided approach. So this from the left side to right side, this is the optic nerve, internal carotid artery, the bifurcation of the internal carotid artery, and the anterior cerebral artery, the middle cerebral artery, and the third nerve, the oculomotor nerve, and the tendril edge. And between the carotid artery and the third nerve is the P2 segment of the posterior cerebral artery. And because the basilar apex was obstructed behind these structures, so there are three triangle between these structures can access to the basilar apex. Is the optic carotid triangle, the super optic triangle, and the carotid oculomotor triangle. And the carotid oculomotor triangle is the largest one of these three triangles. Also, there is a triangle, is the oculomotor and tendril triangle here, but this is seldom used. So we use often we open the carotid oculomotor triangle for basilar tip aneurysm, and then we cut we insist the Liliequist membrane and evacuate the clots in the interpeduncular cisterns very carefully, and follow the P2 segment to the P1 segment. And then we can see the base of the trunk, the ipsy and the contralateral, the posterior cerebral arteries and the aneurysm neck, and then a small short basilar trunk was separated for the proximal control, and the temporal clip was applied for the proximal control. And then the aneurysm neck was more separated. Here, the panorama of the view. You can see this is the aneurysm. Then we apply the permanent clip on the aneurysm neck. Here, the internal carotid artery can be retracted to the medially. And then the ICG angiogram, the aneurysm disappeared. And here, remove the retractor, and we can see the frontal lobe and the temporal lobe, the brain relax. And post-operative CTA's scan, we can 3D reconstruct. We can see the bone, the one-piece bone flap for the orbital zygomatic approach, and then we can review using the 3D reconstruction to review the surgery and to see if there is anything we can improve from this surgery. And here are the key snaps of the surgery. And this is the illustration in the Dr. Lawton's 7 aneurysms. And this is the 3D, this is the CTA reconstruction post-operative. We can see the aneurysm disappear. And this is a preoperative CTA, and the 3 days post-operative. We can see the basal cistern's class was evacuated totally, and here's the clip, and the hydrocephalus was resolved. And this is the second case, is 56 years old female, and loss of consciousness of more than 4 hours, and the preoperative GCS is E1 V1 M2, and has is a grade 4, and it's also the same severe subarachnoid hemorrhage and obstructive hydrocephalus, and this is the postoperative CT scan. And from the 3D reconstruction, we can see the aneurysm. And please notice here is a large P1 and P2 segment of the posterior cerebral artery. We use the right side approach. So during the surgery is obstacle. So here is some videos. We do the contralateral EVD, but after drain about 20 millimeter CSF, the brain is still swelling, and so we do one piece orbital zygomatic approach as that case, and follow the same procedure. This one this is the terminal laminas. We penetrate it to release the CSF, and then the brain next. Here the penetrate the terminal laminas. You can see after the CSF released, the brain next. Here are the steps. I just made some snaps here. The frontal and temporal lobe and the lamina terminalis. Here, open the basal systems, the optic nerve, the internal carotid artery, and remove the clots carefully, and then split the Sylvian fissure. If we want to retract the temporal lobe posterolaterally, we need to coagulate and cutting the brain, the bridging veins to the sphenoparietal sinus. And here, the key structures, the optic nerve, the internal carotid artery, and the third nerve and the tentorial edge. And then this is the lytic membrane. We cut the lytic membrane and remove the clots carefully in the interpeduncular systems. And this one, you can see the posterior communicating artery and anterior parietal artery here. And here is the posterior cerebral artery. This case, he has a large P1 segment. So this is the aneurysm. Be careful, the aneurysm dome, the clots attached to the aneurysm dome. Do not touch that. You just clear the to expose the aneurysm neck is enough, because the rupture spot is often at the aneurysm dome. So here are the some videos. You can see the clipping. At first, please notice I tried to put the clip from the undersurface of the P1 segment, but that is a not angle. So the aneurysm ruptured. But when the aneurysm ruptured, do not panic and try to control the bleeding. And this is the second suction of my system. Here, using the suction to clear the field and then control the bleeding. And then I try to apply the clip from the upper surface of the P1 segment. because the large P1 segment it obstacle the visualization, and then the aneurysm was clipped. This is the before clipping. You can see the aneurysm, and after clipping, the aneurysm disappeared. And this is a 3 days post-operative CTA. You can see the aneurysm disappeared, and also we can see the vessel spasm. And this is another case, is a pseudo aneurysm of the internal carotid artery. This is a 62 years old male, and he suffered sudden onset of severe headache and loss of consciousness for 4 hours. And he had a traumatic brain injury 20 years ago, and his wife described the massive bleeding from mouth and his nose after his trauma. And then he was cured conservatively. And we can see the preoperative CT scan. He has an old scalp fracture of the right side, right frontal bone. And the patient is in the comatose status, and the GCS is 7. The Hunt-Hess scale is of grade 4. It's a severe subarachnoid hemorrhage, and due to the CDA and the DSA, we can see a aneurysm in the internal carotid artery. And we thought it should be a blister aneurysm. So we do the open surgery, and here's some snaps. And it followed the same procedure. And here the clots attached in the rupture spot. And we explore the other side and keep the clots here. And then drill off the anterior clinoid process to expose the internal carotid artery for proximal control. And then we can see here, after we remove the clots, we can see no aneurysm. It's just a tear in the wall of internal carotid artery. Here is a big hole. And this is a dissection video. You can see here, when I dissection, it ruptured because I have exposed the proximal of the internal carotid artery. Then I applied a temporal clip, the first temporary clip for the proximal control. And then the second one came in to control the M1 segment of the middle cerebral artery. And my assistant helped us to clear the field, and then gently and quickly to expose the A1 segment of the anterior cerebral artery. Here is the A1 segment, the bifurcation of the internal carotid artery. And the third clip, temporal clip, came in. And then the bleeding controlled. We can see there's no aneurysm wall. There's a big hole in the internal carotid artery. And then I tried to clip, but it cannot be clipped. So I used a 9-0 proline suture to stitch the tear here. And the ICG angiogram to show that the vessel, the patent is good. And then using a piece of Dura for the reinforce a clip for reinforce the stitch side. And this is a post-operative reconstruction. We can see the vessel is good. The branches are all here. So that's all. That's 3 cases I shared today.
Okay, very good. Thank you very much, Dr. GY. And I'm gonna turn this over actually to a more senior neurosurgeon. I'm not a neurosurgeon. So we'll let Gautam Deva Reddy take over. He's a neurosurgeon from Chennai. Hello, Gautam. Why don't you take over, okay?
Great presentation, Dr. G. Hello, can you hear me?
Yes.
Hi.
Very great
Hello.
presentation. Yeah, very nice. You handled the rupture very nicely in both the cases. It's quite demonstrative. Quite demonstrative. Which cases generally? Which cases you will be doing this? You will be using this corridor, cavernous, not cavernous, ICA and third nerve. Do you regularly do orbitozygomatic for the posterior fossa?
Did you hear him okay? Did you hear him okay?
I'm sorry, I didn't hear clearly.
Yeah, could you repeat the question, please?
Do you regularly do this orbitozygomatic for posterior circulation in Europeans?
Yeah, I'm sorry.
I'm sorry, I can't clear.
Yeah, I know what you mean. I'm having a hard time too understanding. It's you know, it's not so much the connection. I think it's the language. Could you speak a little slower? I'm sorry, Gautam. Could you speak a little slower?
Could you type?
Yes.
For how long you kept the internal carotid closed with the clip, with temporary clip? For how long?
You mean the last one?
Yes.
About 20 minutes. Of course, at first I tried to. This is the first case I faced such complex situation. So at first I don't know how to deal with it. I tried to using clips, but it cannot be apply a permanent clip on such a big hole. So I tried to stitch it. It's a deep. It's very deep, so it's a little bit difficult for. At first, I want to use a 6-0 protein suture, but the needle is big, so I changed the 9-0 protein suture. So it take a little bit longer, but the patient recovered well.
Do you start him on anti-platelet therapy after the surgery?
I'm sorry?
Do you start antiplatelets after the surgery?
Coagulate?
Yes.
Yes.
No, I didn't coagulate.
Was that the question you asked? Go ahead.
Antiplatelet therapy after the surgery, like aspirin or something like this. Clopidogrel.
Yeah, do you give like aspirin after the surgery or any antiplatelet medicines?
I don't get it. I'm sorry.
Well, do you ever give aspirin or antiplatelets after the surgery?
Oh, no, I didn't.
Okay. Well, we have a question from Gautam Deva Reddy.
Yes, I do OZ approach for basilar tip aneurysm, and I do the subtemporal approach, but not for the basilar aneurysm. So I think I'd like to use OZ approach because I think the field is large. I felt confidence to deal with bleeding, and this approach for the high riding and low riding aneurysms is better than the subtemporal approach, I believe.
Okay, you have another question from Kartik Multani. You see the question, right? What is the rationale to choose open surgical repair and such pseudoaneurysm over endovascular flow diversion by malleable stents?
Yeah, because I do open surgery, so I don't have much experience for the endovascular surgery. So, but this case is evaluated by the endovascular guys in my department. They transferred it to me to do the open surgery.
Okay. Khalif, do you have any remarks or questions?
Just wanted to ask Dr. Goi, in your center, do you, if you are doing the endovascular coilings, how often do you do basilar tip aneurysms?
Oh, well, I don't do too much the basilar aneurysm open surgery because most of them to do the endovascular. Yeah.
Okay. All right.
I'm sorry. Can I get a phone?
Yeah, sure. Sure. These things happen. We understand. Okay, if anybody has a question, and okay, Rahul, you have a question. How's your audio, Rahul? Is it okay? Do you want to ask him the question directly? Rahul?
Yeah, okay.
Yeah.
Why
don't you just wait till he's actually on the phone. This is real live TV. So just wait a second. Wait a second while he gets off there. And you understand how a neurosurgeon has to take the call. So we'll just wait a second and be patient. Hello, Zolo, welcome. Hello, Dr. Portilla, welcome. Dr. Elkanati, Sunil, welcome. Joanna, welcome. It'll just be a second, hopefully. Dr. GY will be back. Let me see here. People are on the beach today.
Oh, is that real life picture, John?
No.
Oh, okay.
But it's close. It's only like about a mile away, less than a mile.
And you don't have many people on the beach today?
No, it's illegal. You know it's like, yeah, it's the same probably as Kenya, right?
Yeah, so we can go to the beach still, but restricted from after 5 p.m. it's not allowed.
Right. Oh yeah.
Yeah, after 7 p.m.
Well, unfortunately, in Miami, they have what's called a spring break in March, and they had a lot of New York people down here.
Oh my!
Which is not good. I expected to hit here hard, really.
So New York people are not good anymore.
Well, yeah.
Dangerous.
Okay, Dr. Goy, are you ready?
Yeah.
Yes, I'm sorry. There is
that's a life of a neurosurgeon. We understand. Okay, there's a couple of questions there. Rahul, you want to ask them directly?
Yeah.
Go ahead.
Can you hear me?
Yes, we can.
Yes.
Yeah, sir. If at all you have to cut the PCOM, where do you cut, and in what situation do you cut the PCOM?
The PCOM?
Yeah.
Yes.
Yeah. Do you cut the PCOM? And
no.
No,
You
No,
don't cut
I
the
don't.
PCOM
I
at
don't
all.
cut the
Even if
PCOM because
you try to mobilize it only.
yes, yes. And the second, it didn't show clearly, but the second case, the PCOM is large, so I just mobilize it.
Yeah. The first case, you went through the left side, right? The first
Right
case.
side. Right side.
You went through right side. Okay, okay. I thought it's left side.
Yes.
So when is your indication like towards when do you use a left-sided approach for the basilar tip?
Left side approach, mostly we use right side. Left side because the dominant hemisphere. I seldom use it. Only.
If at all you have to use, then when you will use it? Any indications?
Like multiple aneurysm, you have to use the left side to deal with them.
Okay.
Very
Only.
good. Go ahead.
Okay, fine.
Go ahead.
Thank you. Thank you. That was
okay. Okay, Dr. Hafez has another good question. You want to ask it, Dr. Hafez, directly?
Yes.
Go ahead.
I want to ask you if you prefer to do the surgery for clipping immediately after the rupture or to wait for 7 days or 2 weeks, because there's a controversy about this.
Yes, I understand. I don't wait. I just do the early clipping, no matter when.
Yeah. Professor Goi, is that still a controversy of when to operate on these patients? Dr. Hafez, I think that's no longer controversy. We know what will kill these patients is a rebleed. So
yes,
the earlier you treat the aneurysm, the better. So there's no point of waiting for this vasospasm period or something like that. There are many data. There's a lot of data, a lot of research that shows that the number one killer of patients with subarachnoid hemorrhage is rebleed. So the only way to prevent rebleed is to secure the aneurysm.
Yes, I think in every aneurysm except the basilar tip, there's still controversy about this.
For the basilar tip is still a controversy.
Yeah. Yes,
All right.
That I know.
Okay.
I like to do the early clipping. I don't wait.
Okay.
Okay, we have another question from a neurosurgeon in Ecuador, Stuart Portillo. He says, great presentation, Dr. Goi. In some cases, did you need the posterior clinoid process to improve the vision?
Yeah, that's a good question. Because if you see the second case, is ruptured during the clip. But I cannot for the proximal control because it's a low right aneurysm. The posterior clinoid process obstructed the basilar trunk, so I cannot for proximal control. That because I thought that should be a easy aneurysm to deal with, so I didn't drill the PCP. But I think that's it should drill the posterior clinoid process to expose the basal trunk is more safety.
Okay, very good. More comments or questions from the panelists?
Yeah, one question, please.
Go ahead.
Like, how do you treat a posterior projecting aneurysm? Like, do you still go via the OZ, or you will do a subtemporal and see all the dissect the perforator slowly and then clip it? Posterior projecting aneurysm.
I'm sorry, I didn't get it.
Okay.
How do you tackle a posterior projecting aneurysm? You still go via the OZ, or you go like you take a subtemporal route?
Did you get that? Did you get that?
Posterior dome projecting posterior
communicating artery aneurysm?
No. Basilar tip with the posterior dome. Posteriorly projecting. Dome is projecting posteriorly.
Yeah, I see. I also do the OZ because I like this wide field. because but the posterior how to say that, the posterior it's the penetrators cannot see clearly, but I think
Still you
for
will
me
go
I like
OZ.
this approach.
Okay.
Does that answer the question, or is it clear?
Yeah. Okay.
Okay, thank you.
Okay.
Okay, more comments or questions for Dr. Goy? Okay, there's no hurry. There's no hurry. Okay. Okay, Joanna, any questions or comments? Sorry to prod you or bother you. Lucindo?
One more question.
Go ahead, no problem. You take as many questions as you want.
Any special type of clipping, like you use only simple straight clipping, or you do this tandem techniques or fenestration through the like to take the P1 also within the clip? Hello.
Did you get
any
that?
special clipping techniques? Special clipping techniques.
Any special clipping techniques?
You mean the special clipping techniques?
Like simple, just a simple straight clip, or you do a tandem clip, or you take fenestrated clips like that.
Okay, because I don't deal with more complex the basilar tip aneurysms, so I only use the straight
simple
or a slight curve. Yes, clips. No penetrate clips.
Okay. How do you dissect the perforators, like posterior to the dome of the aneurysm? It's a blind spot, right? How do you dissect it? I mean, how do you dissect it from the aneurysm neck?
In the video I showed just
yeah, I didn't see that. How do you dissect from the posteriorly? How do you dissect the perforators? So
yeah, I cannot, because you cannot see it clearly.
Yeah, it's a blind spot.
Yes, the blind
how do you
spot.
ensure? No, how do you ensure that perforator is not included in that? Because that is very difficult to see in ICG also.
Right. You cannot see it clearly.
Only you will know in post-operative period once the patient gets like deficits or patient doesn't wake up.
Yeah.
There's no other method, right, to know that your perforator is in the clip or not.
Yeah,
or you,
in the subtemporal approach, maybe you can see.
Yeah, in subtemporal, okay. After clipping, do you puncture the dome and then dissect it and to see whether perforator is included in the clip or not? After clipping, you puncture the dome and you dissect it anteriorly to see the perforators.
Oh, I understand. No, yeah, I usually check, but not to adjust the clip.
Okay.
Yeah, no. And but the shortcomings of the subtemporal globe, the approach, you cannot see the contralateral.
Yeah, you can't see the contralateral P1. Yeah.
Yes.
No, thank you.
We have another question from Joanna, a neurosurgeon from Finland. In case of basilar artery aneurysm, what complications have occurred? And regarding the clip itself or any other thing as comorbidities? Thank you.
Okay, so that's as it's the most complications is the perforators sacrifice. The infarct of the thalamus and the middle the perforators sacrifice can have the ischemic consequence.
Oh,
right.
Okay.
I think that's the most complications you may have.
Okay. Okay, let's see. Waleed, you've been quiet. Do you want to ask anything of Dr. Goy?
So it's a very nice presentation.
Thank you.
And I think the three surgeons, they went perfect. Very nice presentation, very nice.
Thank you.
Thank you very much.
Thank you. Okay, let's see. Any more comments or questions? Well, Dr. Goy, thank you very much for a great presentation, and thanks for taking the time on this Saturday. So how are things in Beijing with the corona?
The Beijing corona is the patient is zero for many days.
Great.
And yes, and the government has the tremendous pressure to prevent the income cases.
Right. It's locked. Yeah, like
but,
a lot of countries locked down, right? No.
Right. The China has locked down the border. The foreigners cannot into the China mainland.
Yeah. I don't know if it's that same in the United States. I know there's a ban in Europe and Hawaii. I'm not sure, but definitely it's locked down here in Miami. And yeah, it's legal to go outside for food, but you can't go out unless it's an emergency or food. They don't arrest you, but they tell you to go home. Maybe give you a ticket. Maybe give you a ticket. Now, It wasn't like that before, but now it's like that.
Yeah. 1 month ago, the China is the same thing.
Same thing? Yeah.
Yeah.
Okay. Anybody else? Go ahead.
But now the life here is back to normal.
Great.
Malls and restaurants reopen, and
great.
People go outside to have fun.
Okay, at the hospital, is it back to is just emergency surgery, or is it still only emergency?
No, it's back to normal.
Oh, back to normal. Cool. So you're
Yes.
doing elective cases now, and you probably got a big backlog, right?
Right.
To catch patients to catch up on.
Right.
Okay. How is it in other parts of the world? Gautam, how is it in India? Gautam, you there? You may have stepped away. Let's see here. Go ahead. Hey, Sunil, how you doing?
I'm good. How are you?
Good. Welcome.
It's okay.
I think you know Dr. Goy, right?
Yes, we.
Yeah, I know.
Yeah, we
I know.
met
Yes.
several times.
Yeah.
听说过议员这个梁老师，你好。
你好。Daniel can
看到了
speak Chinese.
Go ahead, speak Chinese if you want. Go ahead.
不是我只是说这个您的这个PPT 太好，我看到了。
好，谢谢
你，
谢谢。
Good to see you, Sunil. Glad you came. You've been coming for a long time. Okay.
No, sir. Two operations, so much busy. So yesterday I didn't do it.
That's okay. We have audio problems, but things will get better. Dr. Goy, it's like getting better with the tool. We'll just get better with these tools the more we use them. So, okay, well, I guess we'll end this broadcast. And I'm not sure what IPE has planned for tomorrow. But one thing I'd like to announce is Juha Hernizniemi, I don't have to even say his last name, is doing a series on basilar tumors, I believe, cavernomas, I believe.
Okay.
Brainstem cavernomas.
Yeah, and of course we invite all you guys to come, and it's exciting for me, and it'd be exciting for a lot of other neurosurgeons around the world. Even South America, I've run into neurosurgeons in Argentina, Ecuador, but that say, when are you going to get Juha? When are you going to get Juha? So anyways, he'll be back. And we hope to see Dr. Goy again up there. And we thank you very much.
Thank you so much.
Okay, we're gonna stay. I'm just gonna stop the recording. Unless anybody has any closing remarks. I guess not. Okay, we'll just close it. Thank you.
Thank you.
Okay, we stopped recording. Okay.
Yeah,
Okay.
John.
Yes.
When is
Yeah,
you are going to do the series?
The Africa?
No, Yuha.
Oh,
Dr.
I'm
Yuha.
not sure. He just said next week, so I don't know what that means.
All right.
So
Okay.
we'll certainly let you know. He wrote to IPE also.
Sure. Thank you.
And he said that IPE wants him to do a series rather than just a one talk, and hopefully he'll
Okay.
do a couple of talks. And you know, Khalif, I think he really likes this platform, and I think he'll be using it more. I hope. I'll keep my fingers crossed. But he's had really good experiences in the past. But I guess he's been kind of locked down a little bit over there and busy setting up all kinds. He's working tremendously hard over there. So I'm glad he took time, and I'm not sure of his schedule, but I'm sure he'll welcome the opportunity to reach all people easily. And it's going to be easy to promote this because it just say Yuha.
Yeah.
You know, I don't have to even say his last name. You know, Khalif, I don't know. John, I don't know. But Yuha, oh, Yuha.
Everybody knows him.
Yeah, well, it's an
It's
unusual name. You know,
Yeah.
so that too, I think. So,
He's in Singapore now, or he's back to?
no, well, I don't know. I didn't even know was he in Singapore? I didn't know.
think
I
he was
just
in
assumed he
Singapore.
was in the hospital in China.
Ah, yes. He's also now. I think he's in China. You're right.
Yeah,
He was
yeah.
in Nepal and then went to Singapore, I guess.
No, he's
and
in
then went
China
to-
because I talked to his assistant.
Ah,
His
okay.
assistant came to this show early and he left.
Okay.
Sen Hu. He's a PhD that's doing research on glioblastoma. Yeah, he's going to help us get Yuha set up. And apparently Yuha, well, we'll see. We'll see. I think he's doing other things in China too, besides neurosurgery. So, but I'm, you know, I'll let him tell us about that. So anyways, yeah, everyone, we have a webcast. Let me show you guys this. I'm going to be like TV, like taking a commercial break. You're frozen there, Khalif. Okay, everyone, we have this broadcast in a couple of hours. It's in about, let's see, 4 hours. This Africa Grand Rounds. And Dr. Cabullo is going to speak about degenerative cervical myelopathy. And then Marco Maloney from Italy, in the midst of the corona, he's seeing corona patients actually in Italy. And he'll tell us about the status of things in Italy when he comes on in about 4.5 hours. And if I don't have everyone's email address, just leave it in the chat box. I think I probably have most of everyone's email address. So if someone, okay. Dr. Gui had to leave. Okay, there you go, Dr. Kartik, I got it. And you'll, like, for example, this webcast this afternoon in 4 hours, Dr. Kartik, you should be getting an email, not only talking about the event, but giving you a link to come in if you so choose. We understand the life of a neurosurgeon. You're on the go. You don't know what's happening. And I think it's a good thing for you to have the option to jump in if you can and just jump out if you can't. Or if you're in here for a while and you got to go. So, any of you guys, Musindo, any of you guys want to talk or say something? You're welcome to. You don't have to, but let me get Dr. Kartik's email there. Okay, your email's there. I got to do that right now. Okay, everyone. I hope to see you at the Africa Grand Rounds. Signing off.